This is the second part of the podcast. We're going to talk about nursing care of the patient with the chest tube. Since the chest tube deals with the patient's respiratory system, this becomes our priority assessment. We want to assess the patient's breathing, make sure it's unlabored and normal. We want to make sure that it's not shallow. Our lung sound should be equal bilaterally. We should not have one lung that has no sound at all. We need to check our dressing site. We need to make sure it's clean and dry and intact. If we have drainage, we need to reinforce the drainage. Let the physician know that we have a large amount of drainage from around the site. The other thing is we need to assess for what we call sub-Q emphysema. If you've not heard this term before, what it is air that collects in the sub-Q space in the tissues, and when you palpate, you will feel like Rice Krispies under the skin. If we were in class, I would have a glove with Rice Krispies in and pass it around, and you could actually feel what that feels like. But I think if I say Rice Krispies, you can picture that in your mind. You want to palpate around the insertion site of the chest tube for the sub-Q emphysema. If you do find it, you want to take a Sharpie marker and mark that area. And every time the site is assessed, you want to make sure that area does not grow. That is a problem if it starts growing, and you need to notify the physician if it does. Your patient should be turned every 2 hours if they cannot get out of bed to help promote gravity drainage. The chest tube cannot always reach all the drainage that's there. And if they're laying in bed, sometimes what we call pockets will develop where the drainage will just lay in the chest and not be able to be drained because the chest tube just can't reach it. Getting out of bed into a chair is the best way to promote gravity drainage. And if your patient is to get up out of bed and they do and have a decent amount of drainage immediately upon getting up, that is just drainage of one of those pockets, and it's totally normal. You also need to assess your drainage system. Make sure appropriate water levels are in the water seal chamber and in the suction chamber if it's a wet system. If it is a wet system, you're going to assess for bubbling in the suction chamber. If it's a dry system, you're going to look at the dial, make sure that it's set at the appropriate amount of suction and that the bellow is expanded, meaning it's hooked to suction. You're going to assess for bubbling and titling in the water seal chamber. Titling is normal. Absence of titling, remember, means obstruction. And bubbling, do they only bubble when they cough, or is it continuous bubbling? If it's continuous bubbling, it's an air leak. Yesterday at work, I got a patient from the OR right after lung surgery, and I had the following video shows you what an air leak will look like in the drainage collection system. So first we look at the water seal chamber. See the bubbles in here? And you can see the ball that's titling with the respiration. It goes up with inspiration, down with expiration. We see a dependent loop here. The purpose of this was to show you how the drainage vacillates with the patient's breathing. I move the suction tubing so you can see the dial and see the amount of suction was set to -10 cms. The bellows expanded, meaning it's hooked to suction, and you can actually hear the bubbles in the chamber. If we are going to assess for an air leak, down here at the last point, make sure you're clamping the chest tube with padded or soft tip clamps. You don't want to damage the tubing. It's very soft and you need to have soft tips. If you use a regular hemostat, you need to put a piece of gauze around the chest tube if you're going to use a regular hemostat. You start at the patient and work your way down to the drainage collection system, checking for the air leak, clamping and unclamping. You're looking for the bubbling to stop when you clamp. When the bubbling stops, it gives you an idea of where the air leak might be. If it stops immediately on the first clamp at the insertion site, the air leak's within the patient. And if it doesn't stop until you get to the drainage collection system, then that's where the air leak's occurring. A couple other things. Don't allow those dependent loops like you saw in the video. It will increase intrathoracic pressure. Always keep the drainage system at the below the level of the patient's chest. If you're getting in and out of bed or ambulating with the patient, make sure it stays below the patient's chest level so that fluid cannot reflux back into this into the pleural space. The other thing is we need to document the amount, color, and characteristics of our fluid. We need to note the amount. Remember I said about drawing with a Sharpie, marking the level that it's at and the time so we know. The color, is it bright red, dark red? Is it serous sanguineous, blood, meaning blood mixed with fluid, or is it serous? The characteristics of the fluid, is it thick, is it thin, is there clots in the fluid? This is a picture of a dependent loop. Like I said, it can cause pressure, increase pressure in the lung, and it can actually cause the lung to collapse again. Stripping chest tubes. We do not strip chest tubes. According to NCLEX, this is not allowed. What we do is milk them, which is gentle squeezing of the tubes, to help move clots along the tubing and prevent obstruction of the tubing with the clots. What happens with stripping is it can cause sharp increase in intrapleural pressure and causes damage to the lung tissue itself. However, if you work in an open heart unit where patients have had surgery and have chest tubes, the surgeon may instruct you to strip the chest tubes, and in that case, it is perfectly all right. Just remember, for NCLEX purposes, it's never okay to strip chest tubes. So when do we call the physician or rapid response team? Anytime our patient will have a sudden increase or a sudden onset of dyspnea, they decrease their O2 saturation. These are all signs of respiratory distress and could be signs of a developing tension pneumothorax. If the chest tube becomes disconnected or falls out, if it becomes disconnected, clamp it right away and put the end of the chest tube that comes out of the patient into a cup of sterile water. And then replace the connector and tubing to the drainage system, change all that out. Notify the doctor, he'll probably order a chest x-ray to make sure the chest tube's okay and air hasn't gotten into the pleural space. If the chest tube comes out, this is really hard to happen because these chest tubes are stitched into the skin to keep them in place. But if they're not stitched properly or tight enough, or if there's enough force exerted on that chest tube, say it gets caught in a side rail and the patient goes to turn, or you go to put the side rail down and it's caught, it's enough of pressure to break that stitch and pull the chest tube out. If this happens, you want to immediately place a dressing over the site, a 3-sided dressing, and call the doctor to get a chest x-ray. Make sure that you have not developed a pneumothorax. The other thing is drainage. If you're draining consistently and then have a complete stoppage in your drainage or have a great increase in your drainage, this is the time when the physician needs to know, and they're going to give you orders of what to assess. If it's a great increase in drainage, he's going to probably order an H&H, a PT, a PTT to see if there's bleeding issues. If it completely stops, there might be some type of obstruction. Either way, the doctor needs to know. When it's time for the chest tubes to be removed, usually this will be when the issue is resolved. It's a pneumothorax, the lung has healed. Or if it's post-surgery, it's when the drainage has become less than 100 in a 12-hour shift. That's 100 mLs in a 12-hour shift. They'll decide the chest tubes can be removed. If it was for a pneumothorax, some physicians opt to do a clamp test where they clamp the chest tube for 4 hours, get a chest x-ray, and make sure that the lung remains expanded. And then if it does, then they'll remove the chest tube. Some physicians just assess the patient's clinical presentation and the absence of an air leak in the system to make that determination. So it's every physician's preference. When we go to remove chest tubes, this is done by the physician, a PA, a nurse practitioner. It is not done by us. They will coach the patient with deep breathing, and they cut the stitches. They prepare their dressing with Vaseline gauze or some petroleum-based gauze covered with sterile 4x4s. And what they'll do is they'll have the patient take a deep breath in and blow out, and they'll practice that once, and then they'll have the patient take a deep breath in and they'll tell them to blow out, and while they're blowing out, they'll pull the tubes out of the chest. This is to prevent any air from rushing back into the chest, into the pleural space. Immediately, they'll secure the dressing, and then they'll order a chest x-ray to follow up and make sure there's no pneumothorax. Your job is to continue monitoring their breathing, their lung sounds, and their pulse oximetry to make sure that they're okay after removal. This slide is just showing someone getting prepped for chest tube removal. Now, since I don't have you face-to-face in class, I took some pictures of an actual chest tube so that I could show you what it looks like. This is the complete entire chest tube that would be inserted into the patient. Note the holes at the top. These are what the drainage goes into the tube with, and then there's numbers. These are centimeter marks on the tube. Here's a closer picture of the holes on the tube. A closer picture, you can see the numbers markings on the tube. Here you see the top of the tube with the holes and then the numbered system. This is at the bottom of the tube. It's going to show you what size the tube is. This happens to be a 28 French. This is about a medium-sized tube. All right, so this first link I want you guys to watch. This is the actual insertion procedure of a chest tube, and you can see what that's like. The next one is also a nice quick review of chest tubes. And she mentions her website with NCLEX questions, which I've taken some of those NCLEX questions and we will review them in the Zoom session, but she has many more than I was able to have time to capture off her website. So please write down your questions and I'll answer them in our Zoom session.